associated with comorbidities and complications such as bronchial asthma, diabetes mellitus, chronic kidney disease, heart disease, cerebrovascular accidents, and so on. So now let's discuss the first clinical situation. How to manage hypertension in presence of bronchial asthma or COPD. Hypertension is a frequent coexisting clinical condition with bronchial asthma or COPD. Hypertension may arise due to increased usage of systemic steroids, beta-2 agonists, nasal decongestants, and these drugs are known to induce or exacerbate high blood pressure. High blood pressure is linked to increased worsening of severity of asthma, decrease in lung function, the forced expiratory volume decreases, and this can increase the cardiovascular risk, leading to increased mortality. So which are the blood pressure lowering agents that are selected in presence of bronchial asthma? The major antihypertensive agents are ACE inhibitors or ARBs, beta blockers, calcium channel blockers, and diuretics. The drugs that are considered to be safe in the management of hypertension are calcium channel blockers and angiotensin receptor blockers. The ACE inhibitors are known to inhibit the ACE enzyme and increase the level of bradykinin, which is an inflammatory mediator and can induce cough. Therefore, ACE inhibitors are avoided and angiotensin receptor blockers are preferred over ACE inhibitors in the management of hypertension in bronchial asthma. When it comes to beta blockers, the non-selective beta blockers antagonize the beta-2 receptors of the bronchial smooth muscles and decrease the effectiveness and the clinical benefit of the beta-2 agonists that are used in asthma. So this can increase the risk of bronchospasm and cause exacerbation of asthma. Therefore, non-selective beta blockers are avoided in bronchial asthma, and if the blood pressure response is poor, cardioselective beta blockers can be used with caution. When it comes to the use of diuretics reduce the plasma level of potassium, and this can increase the risk of hypokalemia by causing potentiation of the hypokalemic effect that is produced by glucocorticoids and beta-2 agonists. As it is known that beta-2 agonists increase the transport of potassium into the cells, decreasing the plasma potassium concentration and causing hypokalemia. So diuretics potentiate the hypokalemic effect of glucocorticoids, beta-2 agonists that are used in asthma, and this can increase the risk of hypokalemia. Therefore, the drugs of choice for lowering blood pressure in presence of bronchial asthma are the calcium channel blockers and angiotensin receptor blockers. If the blood pressure response is not adequate, cardioselective beta blockers can be used, and diuretics such as thiazide diuretics or thiazide-like diuretics can be used with caution. The next clinical situation is how to manage hypertension in a diabetic patient. Now, before initiating antihypertensive drug therapy, it is important to exclude postural hypertension, which is marked in diabetes due to autonomic neuropathy. The antihypertensive treatment is initiated when the blood pressure is greater than 140 by 90 mm of mercury, and the target blood pressure reduction goal should be less than 130 by 80 mm of mercury. Amongst the various antihypertensive agents, ACE inhibitors or angiotensin receptor blockers are reported to reduce albuminuria or proteinuria and decrease the progression of diabetic nephropathy. Therefore, these drugs are preferred choice in the management of hypertension with diabetes. But do remember that ACE inhibitors are not combined with angiotensin receptor blockers because they can increase the risk of hyperkalemia and renal adverse effects. If the blood pressure response is not adequate with ACE inhibitors or ARBs, calcium channel blockers can be added, or thiazide-like diuretics can be added to the therapeutic regimen. Moving on to the next clinical situation, that is hypertension with chronic kidney disease. Here, the antihypertensive drug therapy can be initiated when the blood pressure is greater than 140 by 90 mm of mercury. As mentioned in diabetes, ACE inhibitors and angiotensin receptor blockers are known to reduce albuminuria or proteinuria and decrease the progression of chronic kidney disease than any other antihypertensive agent. So they are preferred drugs and they should be included as a component of the treatment strategy in the management of hypertension with chronic kidney disease. For greater antihypertensive effect, AC inhibitors can be combined with a calcium channel blocker or a diuretic. When it comes to the use of diuretics in chronic kidney disease, do remember that when the glomerular filtration rate is less than 30 ml per minute, thiazide diuretics should be avoided because thiazide diuretics reduce the renal blood flow and decrease the creatinine clearance and therefore should not be used in chronic kidney disease. Thiazide diuretics should be replaced with loop diuretics when the glomerular filtration rate falls below 30 ml per minute because loop diuretics have no effect on the renal blood flow and is safe in chronic kidney disease. Thus, the drugs that are recommended in the management of hypertension with chronic kidney disease are ACE inhibitors or angiotensin receptor blockers combined with calcium channel blockers or diuretics, preferably the loop diuretics are used. This can be discussed under three headings: hypertension with coronary artery disease, hypertension with heart failure, and hypertension with arrhythmias. So the first one, hypertension in presence of coronary artery disease. In patients with symptomatic angina, beta blockers or calcium channel blockers are preferred drugs in the management of hypertension because these drugs help to relieve angina by decreasing the workload on the heart and relieve chest pain. Also, beta blockers are preferred drugs post myocardial infarction because they reduce the risk of arrhythmias in the scarred ventricular myocardial tissue by decreasing the cardiac automaticity. So beta blockers, by decreasing the automaticity in the ischemic myocardium, decreases the risk of ventricular arrhythmias. Therefore, beta blockers are recommended drugs in the management of hypertension after myocardial infarction. Next is hypertension with heart failure. Hypertension is a leading cause of heart failure. Long-term hypertension can cause left ventricular hypertrophy, and because of the ventricular hypertrophy there is failure or impairment of relaxation of the ventricle, and this can cause diastolic dysfunction and causing diastolic heart failure. In spite of the ejection fraction being normal, the systolic function being normal, but there is a failure in the diastolic function and this can cause heart failure with preserved ejection fraction. So ejection fraction is preserved, the systolic function is normal, but there is heart failure because of failed diastolic function. So when there is left ventricular hypertrophy, ACE inhibitors or angiotensin receptor blockers and calcium channel blockers are more effective than beta blockers in causing left ventricular regression. Therefore, these drugs are preferred in presence of left ventricular hypertrophy. Also, heart failure can occur because of reduced ejection fraction, and in this condition, ACE inhibitors or angiotensin receptor blockers, beta blockers and mineralocorticoid receptor antagonists such as spironolactone, eplerenone are preferred drugs. So these drugs are known to reduce cardiac remodeling and improve survival in patients with heart failure and reduce hospitalizations in patients with heart failure. Diuretics, particularly the loop diuretics, are preferred in heart failure patients as they reduce pulmonary edema, reduce the congestive symptoms and help in symptomatic relief. The next clinical situation is hypertension with arrhythmia. Hypertension predisposes to arrhythmias including ventricular arrhythmia. The most commonly occurring arrhythmia is atrial fibrillation. In atrial fibrillation, the atria beats at a rate 300 to 500 per minute and these impulses pass on to the ventricle, increasing the ventricular rate. Therefore, drugs that help to control the ventricular rate in atrial fibrillation such as beta blockers and calcium channel blockers, particularly the non-dihydropyridine groups such as verapamil and diltiazem, are preferred in the management of hypertension with atrial fibrillation as they help to reduce the ventricular rate in atrial fibrillation. But an important drawback of verapamil and diltiazem is that they have selective action on the heart and they have cardiac depressant property. And because of cardiac depressant property, this can predispose or precipitate heart failure in patients with reduced left ventricular systolic function. To overcome this drawback, beta blockers can be combined with digoxin, and digoxin is a positive inotropic agent. It increases the contractility of the heart, increases the cardiac output. Thus, the combination of digoxin with beta blocker or calcium channel blocker helps to gain control over the heart rate and maintains the heart rate in patients with atrial fibrillation and hypertension. The next clinical situation is hypertension with cerebral stroke. Hypertension is a leading risk factor for cerebral stroke. Stroke can be hemorrhagic stroke, ischemic stroke or recurrent stroke. In hemorrhagic stroke, the blood pressure may be markedly elevated and this high blood pressure can cause expansion of the hematoma, increase the risk of death and worsen the prognosis of neurological recovery. So the systolic blood pressure should be maintained between 140 and 160 mm of mercury. Therefore, when the systolic blood pressure is greater than 220 mm of mercury, blood pressure is gradually lowered using parenteral agents such as IV labetalol, nitroglycerine, sodium nitroprusside, nicardipine. But if the blood pressure is less than 220 mm per minute, blood pressure can be gradually lowered using oral agents such as clonidine and labetalol. Thus, in hemorrhagic stroke, blood pressure lowering improves clinical outcome and the blood pressure should be maintained between 140 and 160 mm of mercury. Next is how to manage hypertension in acute ischemic stroke. In acute ischemic stroke, routine blood pressure lowering before hospital admission must be avoided. This is because rapid lowering of blood pressure can increase the risk of cerebral ischemia, further worsening the clinical condition. Therefore, it is important to withhold antihypertensives until the blood pressure is markedly elevated, that is greater than 220 by 120 mm of mercury. Secondly, it is important to understand that ischemic stroke is due to the formation of clot in the cerebral artery which decreases the blood flow and oxygen to the brain and causing ischemia. Therefore, a key consideration in managing hypertension in ischemic stroke is to see whether the patient will receive thrombolytic therapy. This is because observational studies have shown that if the blood pressure is elevated and the patient is undergoing thrombolytic therapy, then there is increased risk of intracerebral hemorrhage. So there is increased risk of cerebral bleeding if the patient is undergoing thrombolysis and the blood pressure is elevated. In this case, if the blood pressure is markedly elevated and the patient is eligible for thrombolysis, their blood pressure should be gradually lowered to less than 180 by 110 mm of mercury using parenteral agents such as IV labetalol, nitroglycerine or nicardipine. The blood pressure should be maintained at 180 by 110 mm of mercury at least for first 24 hours during or after thrombolysis. On the other hand, if the blood pressure is elevated and the patient is not eligible for thrombolysis, then gradual lowering of blood pressure can be done, but the blood pressure should not be lowered more than 15% in the first 24 hours. So rapid lowering of blood pressure should be avoided and this can be done using parenteral agents such as IV labetalol, nitroglycerine or nicardipine. Next we move on to the treatment of endocrine hypertension. Hypertension can occur secondary to endocrine causes such as pheochromocytoma, primary aldosteronism, Cushing syndrome, hypothyroidism or hyperthyroidism can lead to hypertension. Hyperparathyroidism can also cause hypertension. So to treat hypertension, it is important to correct the underlying cause that is responsible for hypertension. For example, in case of pheochromocytoma, where there is a tumor of adrenal medulla, increased release of epinephrine and norepinephrine causing elevated blood pressure, and in this case, combination of alpha blockers and beta blockers can be used and resection of the tumor can be done. In primary aldosteronism or Cushing syndrome, where there is excessive cortisol or excessive aldosterone in the circulation, so mineralocorticoid receptor antagonist, that is spironolactone or eplerenone, can be used. Both hypothyroidism and hyperthyroidism can give rise to hypertension. So in hyperthyroidism, hypertension can be treated using anti-thyroid drugs and propranolol. And in hypothyroidism, levothyroxine is used for treatment. In hyperparathyroidism giving rise to hypertension, resection of the tumor can be considered and vitamin D supplements can be used. So in this lecture, we have learned how to manage hypertension in various disease conditions such as bronchial asthma, diabetes, chronic kidney disease, heart disease, endocrine causes and so on. So thanks for watching. Please like and subscribe to this channel.